Hello everyone and welcome to our module on the menstrual cycle. Let's start by reviewing the female reproductive system in terms of how the hormones work. So the hypothalamus releases GnRH onto the anterior pituitary, and that stimulates the pituitary gland to release the gonadotropins, which are luteinizing hormone and follicle stimulating hormone, otherwise known as LH and FSH. When these hormones reach the female ovaries, they trigger the release of sex hormones like estradiol and progesterone, and it's these hormones that drive the menstrual cycle. Before we get into the menstrual cycle, let's briefly review some basic principles of how the ovaries work. So the ovaries contain follicles, which are spherical collections of cells that contain a single oocyte near the center of the follicle. The oocytes in the follicle are surrounded by theca and granulosa cells, and these are cells that produce hormones. These are the cells that respond to luteinizing hormone and follicle stimulating hormone. In each menstrual cycle, one dominant follicle emerges and releases its oocyte, and when this happens, this is called ovulation. So the menstrual cycle refers to a series of changes that occur in the ovaries and the endometrium over and over again throughout the reproductive years of a woman's life. In the ovary, you can divide the menstrual cycle into phases. There's the follicular phase, which is where the follicles grow. Then there's ovulation. That's followed by the luteal phase, which prepares for pregnancy, and we'll talk more about this in a minute. In parallel with these phases in the ovary, there are changes occurring in the endometrium to prepare for pregnancy. The first half of the menstrual cycle is called the proliferative phase of the endometrium, and the second half is called the secretory phase. So let's take a look at this diagram, which shows the changes in the ovary during the menstrual cycle along the top, the hormonal changes in the middle, and the changes in the endometrium along the bottom. I'm going to start by going through the hormonal changes because these changes drive everything that's happening in the ovaries and the endometrium. So this is ovulation in the middle of the menstrual cycle, and everything on this side of ovulation, in other words, everything before ovulation, is the first half of the menstrual cycle. And the major hormonal change in the first half of the menstrual cycle is that levels of estradiol coming from the ovaries are slowly rising, and then as the time of ovulation approaches, they begin to rise more rapidly. As this is going on, as the estradiol levels are rising, follicles are being recruited in the ovaries and they are maturing, and one dominant follicle is emerging, and that's the follicle that will eventually release its egg at the time of ovulation. Down at the bottom in the endometrium, the first half of the menstrual cycle, as I said before, is called the proliferative phase. At the very beginning of this, that's when menstruation is occurring. So remember that the previous menstrual cycle ends right here. So at the start of the next menstrual cycle, you have menstruation for a few days where the endometrial lining is being shed. But once that's complete, then the endometrium begins to grow. This is called proliferation, and this is the proliferative phase. And so the beginning of the menstrual cycle, after menstruation's done, in the endometrium, what's happening is that the endometrial lining is proliferating and growing in size. In the middle of the menstrual cycle is when you have ovulation, and the trigger for this is a surge in the release of luteinizing hormone from the pituitary gland. There's also a rise in the FSH release, but it's the LH surge that's very important for triggering ovulation to occur. After the LH surge and after ovulation, we enter the second half of the menstrual cycle here. The main thing that's going on in terms of hormones in this half of the menstrual cycle is that progesterone is being released by the ovaries, and that's because a structure has formed in the ovaries after ovulation called the corpus luteum. You can think of the corpus luteum as a temporary endocrine gland that forms in the second half of the menstrual cycle, and its only job is to produce progesterone, and that's why progesterone levels are high in the second half of the menstrual cycle. And what progesterone does in the endometrium down at the bottom here is trigger the secretory phase. In this phase, the endometrium stops growing, its size stabilizes, but it begins to secrete substances to prepare for implantation if pregnancy occurs. Now the thing to know about the corpus luteum is it has a short lifespan, so if pregnancy doesn't occur, it will degenerate, and when it degenerates, the progesterone levels will fall, and that's why this black line is falling here. And when the corpus luteum degenerates and the progesterone levels fall, that's what triggers the end of the menstrual cycle and the beginning of the next one, and that's what triggers menstruation. So menstruation occurs when there's a drop-off of progesterone. This is sometimes called progesterone withdrawal. That's what leads to menses each menstrual cycle. So now let's talk in a little bit more detail about those phases of the menstrual cycle I mentioned on the last slide. Remember that the first half of the menstrual cycle is everything from the start of menstruation to the LH surge and ovulation. This is called the follicular phase in the ovaries because the follicles are growing, and it's called the proliferative phase in the endometrium because the endometrial lining is proliferating. The major hormonal event in the first half of the menstrual cycle is slowly rising estradiol levels. A dominant follicle will emerge and its oocyte will be released at ovulation, and that's the end of the first half of the menstrual cycle. The duration of this portion of the menstrual cycle varies in length from 10 to 14 days, and as I said, the uterus is proliferating. That's why it's called the proliferative phase. The thickness can increase as much as 10 times from the beginning of the proliferative phase to the secretory phase. And all the elements of the endometrial lining, the glands, the stroma, the blood vessels, they're all growing in size as part of this proliferative phase. So ovulation is the middle of the menstrual cycle, and this is triggered by the mid-cycle surge in luteinizing hormone release from the pituitary gland. When those estradiol levels in the first half of the menstrual cycle get high enough, they trigger the LH surge. This is triggered by an increased frequency of GnRH pulsatile release from the hypothalamus. The oocyte is released from the dominant follicle about 36 hours after the LH surge, and this is the basis for ovulation testing in women who are trying to become pregnant. They can detect luteinizing hormone in their urine, and when this is present, they know they've just had the LH surge and they're about to ovulate, and that's when women are fertile. There's also a phenomenon that occurs at the middle of the menstrual cycle in some women called Mittelschmerz. This refers to mid-cycle mild unilateral pain. It's due to enlargement of the follicles or follicular rupture with bleeding. It's usually relatively mild and it resolves within hours or days, but it can sometimes mimic other disorders like appendicitis because there can be the acute onset of right lower abdominal pain. So then after ovulation, we enter the luteal phase of the ovaries, where the corpus luteum is making progesterone, and the secretory phase of the endometrium. As I said a few slides ago, the corpus luteum forms in the second half of the menstrual cycle. That's why it's called the luteal phase. The corpus luteum is a temporary endocrine gland that forms from a follicle, and its major job is to release progesterone. Progesterone inhibits proliferation of the endometrium, so it will stop growing in size like it did during the proliferative phase, but it will begin secreting lots of substances that are necessary to prepare for the embryo to implant, and that's why the second half of the menstrual cycle is called the secretory phase. If pregnancy does not occur, eventually the corpus luteum degrades and there's a fall in the progesterone level, and this is what triggers menstruation. And usually the timing from ovulation to menstruation, in other words, the timing of the second half of the menstrual cycle, is fairly standard at about 14 days for most women. Now, if fertilization occurs, in other words, if a pregnancy develops, then the embryo will start to make HCG, and this will maintain the corpus luteum so that it won't degrade and progesterone production will continue. Because of continued progesterone production, there won't be menses, and the progesterone will inhibit LH and FSH release, so another menstrual cycle will not begin. If there is no fertilization or pregnancy, though, then as I mentioned before, progesterone levels will fall. That's what's shown here, where this black line starts to go downward. When this happens, this leads to vasoconstriction of spiral arteries in the uterus, and this leads to collapse and desquamation of the endometrium, and that's what leads to menses every menstrual cycle. So now that we've talked about the menstrual cycle in general, for the rest of this video, I'll talk about some common problems in gynecology that are related to the menstrual cycle, and we'll start by talking about anovulation. So anovulation is an absence of ovulation, and if this occurs, there won't be a luteal phase, and the corpus luteum won't form, and there'll be no progesterone release. There will, however, be continued estrogen release, which will cause the endometrial lining to grow, but there won't be normal menses because you don't have the progesterone exposure and withdrawal that is required for normal menses. So as a result, the endometrium is going to grow and irregularly shed and bleed, and this is going to lead to abnormal uterine bleeding, which I talk about in detail in another video. Women with anovulation can go several months without bleeding, and they can appear to have amenorrhea, and then they can have spotting or heavy bleeding. They often have a very irregular pattern of uterine bleeding. And anovulation occurs in special circumstances. The classic cause is polycystic ovarian syndrome, which I talk about in another video. It's also common around the time of menarche and as women are approaching menopause in the perimenopausal period. So when women have PCOS or they're approaching menopause and they have abnormal uterine bleeding, this is often due to anovulation. And in addition to causing abnormal uterine bleeding, anovulation can also cause infertility, and women who have polycystic ovarian syndrome have problems with infertility for this reason. The premenstrual syndrome, or PMS, is a collection of physical and mood symptoms that occur in some women around the time of menses. The symptoms usually begin 3 to 5 days before menses, and there are lots of potential physical and mood symptoms. Up to 150 different symptoms have been described. The most common behavioral symptom is mood swings, and the most common physical symptoms are bloating and fatigue. And it's called the premenstrual syndrome because symptoms resolve with menses, and when women enter the follicular phase of the next menstrual cycle, they are symptom-free. The diagnosis of the premenstrual syndrome is made clinically. Many gynecologists ask women to record their symptoms prospectively for 2 months, and the idea here is to confirm that the symptoms come on as menses approach and then resolve when menses are completed. According to the ACOG criteria, patients have to have at least one symptom that leads to impairment in functioning, and then patients also have to be symptom-free in the follicular phase, which means in the next menstrual cycle after menses are completed. And then it's also important to know that you need to exclude thyroid disease and other psychiatric disorders. Hypo or hyperthyroidism can lead to physical and mood symptoms that can mimic PMS, and there are a number of psychiatric disorders that can cause the mood symptoms that you can also see as part of the premenstrual syndrome. PMDD is the premenstrual dysphoric disorder, and this is a severe form of PMS. Women with this form of PMS for their mood symptoms often have prominent symptoms of anger and irritability. In order to meet the diagnostic criteria for PMDD by the DSM-5, at least 5 symptoms have to be present before menses in most menstrual cycles. The DSM criteria are shown on this slide. Women must have at least one of the criteria on this side of the table, and then they can have one or more of these criteria here, and they have to reach a total of 5, and these have to be present before menses in most menstrual cycles. The treatment of the premenstrual syndrome depends on severity. For women with mild PMS, lifestyle interventions are often very helpful. If these women are able to exercise more or reduce stress, this often helps a lot. You can ask your gynecology attendings about this, but there are many different lifestyle interventions patients have used to improve symptoms of mild PMS. For women with severe PMS or PMDD, combined oral contraceptives often improve the symptoms significantly, and SSRIs can also be helpful. For the rest of this video, I'm going to talk about menopause, which refers to the permanent cessation of menstrual periods. And this is caused by the depletion of ovarian follicles. Women are born with a limited number of oocytes, and when all those oocytes and the follicles have been depleted from the ovaries, that's when menopause occurs. The median age of onset for menopause is 51 years, and you should know that menopause is usually preceded by irregular menses. For many months or years before women undergo menopause, they often have irregular menstrual periods. After menopause, there's a fall in the release of estrogen from the ovaries as well as a release of progesterone. And because there are less estrogens coming from the ovaries, the levels of FSH and LH will climb as the pituitary gland tries to stimulate the ovaries to release more estrogens, but the ovaries aren't able to respond because they've been depleted of follicles. The main clinical symptom of menopause is hot flashes. These are also called vasomotor symptoms or hot flushes, and this refers to a subjective sensation of warmth where the woman essentially feels hot for a brief period of time. Usually hot flashes last a few minutes and then pass, and they're associated with a drop in estrogen level. They're a sign of declining estrogen levels. Menopause is also associated with vaginal atrophy. The vaginal mucosa can become thin, dry, or friable from loss of estrogen stimulation, and this is often treated with topical estrogen creams. And then besides hot flashes and vaginal atrophy, fatigue and sleep disturbances are also common in women when they undergo menopause. Menopause is associated with a higher risk of osteoporosis. That's because the loss of estrogen leads to increased bone loss and lower bone mineral density. There's also an increased risk in cardiovascular disease after women have undergone menopause. This may be partly due to estrogen deficiency, although the exact reason why the risk is higher after menopause is not completely understood. And then the fall in estrogen alters the serum lipids. After women undergo menopause, they tend to have a decline in the HDL level and a rise in the LDL level. Let's talk about the evaluation of menopause. So women with menopause often present with hot flashes and irregular menses. And the diagnosis is usually made clinically if a woman has these symptoms and she's approaching the usual age of menopause. The technical definition requires 12 months of amenorrhea not due to another cause for a woman to be considered to have undergone menopause. And then remember that the average age of menopause is 51 years. So for women who present with evidence of menopause and they're under 45, testing is usually done to exclude other causes of amenorrhea. This usually includes a pregnancy test and a TSH level as well as a prolactin level. You can also measure the FSH level because, as we'll talk about in a minute, that's elevated when women are entering menopause. So this can confirm that the cause of amenorrhea is menopause and not something else. So as I just alluded to, there are serum hormone level changes that are associated with menopause. Measuring serum hormones is not required for a diagnosis of menopause, but it's often helpful to exclude other causes of amenorrhea and confirm that menopause is the reason that the woman has stopped menstruating. If you look at this graph on the screen, time zero is menopause, so after menopause, estrogen levels fall, and one of the major changes is that the level of FSH climbs significantly. So a normal FSH is 6 to 10. In women who are perimenopausal, it can be 10 to 30, and in women who have entered menopause, it gets above 30 and often above 40. Also in menopause, the FSH to LH ratio is usually greater than 1. This is because FSH and LH both rise, but FSH rises more, and that makes the ratio higher than 1. Let's talk about symptom management in menopause. So as I said before, the main symptom is hot flashes, and this is often what women seek treatment for. And you should know that the first line intervention for hot flashes is lifestyle modifications. If women can keep the temperature in their home cooler and wear lighter clothing and use things like fans, this is often helpful for symptoms of mild hot flashes. There are also lots of herbal supplements that women can take. Some of these contain modified estrogens, and they're a very popular way to treat menopausal hot flashes. And then the ultimate intervention for treatment of hot flashes is hormone replacement therapy, which involves prescribing estrogens to raise the estrogen level. The primary goal of prescribing hormone replacement is only to treat hot flashes. In general, hormone replacement isn't used any longer for long-term prevention. There was a time when hormone replacement was recommended to prevent osteoporosis and coronary disease. A number of studies, however, have shown that the risks outweigh the benefits of hormone replacement therapy for prevention of these long-term complications of menopause. So in most practices, the main indication for hormone replacement therapy is to treat hot flashes in women who aren't able to improve their symptoms with lifestyle modifications or supplements. So hormone replacement therapy involves prescribing estrogens and/or progestins to women to limit menopausal symptoms like hot flashes. The estrogens limit the hot flashes, but you need to add a progestin if the woman has an intact uterus. If you give a woman with an intact uterus just estrogens, she will have endometrial growth. This will lead to endometrial hyperplasia and irregular bleeding. So in women who have an intact uterus, you have to also give progestins to prevent hyperplasia and bleeding from occurring. This isn't necessary in women who have had a hysterectomy, but in women who have an intact uterus, progestins need to be added to estrogens. There are many different ways to administer hormone replacement therapy. I'll touch on some of the key points on this slide. So a very popular way to give estrogen is through a transdermal estrogen patch. This has been shown to have less thrombotic risk compared to oral estrogen, and we'll talk in a minute about the risks of hormone replacement, including the risks of thrombosis. There are also oral estrogen preparations and oral progestin preparations. And you should be aware that many women do not take progestins every day for hormone replacement. Instead, they take them cyclically. When women take progestins every day, they can develop mood symptoms like anxiety or depression. So instead, many women take them intermittently, only several days per month, or sometimes even only several days per quarter. The way this works is when the woman takes the progestins and they wash out, she will have withdrawal bleeding and shed the endometrial lining. And this will prevent the development of endometrial hyperplasia and carcinoma. And so it's been shown that in order to have protection against endometrial hyperplasia and carcinoma, women only need to take progestins several days per month or even less frequently. And so many women do this to avoid having to take progestins every day. So there are some risks associated with hormone replacement therapy, and that's why it's generally reserved only for women who have significant symptoms like hot flashes. There is an increased risk of DVT, stroke, and myocardial infarction. That's because the estrogen component of hormone replacement therapy raises the amount of clotting factors in the blood. There's also an increased risk of developing breast cancer because estrogens and progesterone can stimulate breast tissue growth. The major contraindications to hormone replacement therapy are shown on this slide. So in women with a history of estrogen receptor positive or progesterone receptor positive breast cancer, you don't want to give these women estrogens or progestins for obvious reasons because you can drive growth of the cancer. The same is true of women who have a history of estrogen-dependent endometrial cancer. Because of the increased risk of blood clots, HRT is contraindicated in patients with a history of coagulopathy, a prior venous thromboembolic event like a DVT or PE, a prior stroke or TIA, or coronary artery disease. And then these hormones are metabolized by the liver, so HRT is usually avoided in women who have active liver disease, and it's also avoided in women who have unexplained vaginal bleeding because the estrogen component can cause vaginal bleeding, so you don't want to give HRT to any woman who has vaginal bleeding that you haven't yet worked up and identified the cause for. I'll finish with one slide on primary ovarian insufficiency. This refers to impaired ovarian function before 40 years of age. Basically, this is the same presentation, the same clinical syndrome as menopause, but it's occurring at a very early age outside the range that is usually seen for normal menopause. Other than the age at which it occurs, the presentation and treatment are similar to menopause. And there are a number of potential underlying causes of primary ovarian insufficiency. Women who have received chemotherapy or radiation therapy can have ovarian failure at a very early age. There are familial cases, and women can have this condition when they have autoimmune disease. There are also a number of genetic disorders that lead to primary ovarian insufficiency. Women who are Fragile X mutation carriers commonly develop this problem, and it's a classic complication of Turner syndrome. And that concludes our module on the menstrual cycle.